So I'm Dawn. I work in the cardiac cath lab. Actually, we're right here, so if you want to head on in, I'll show you around a little bit. So this is our cath lab. So it says cardiovascular, but for us it's cardiac cath. So that's everyone short is just cath. So if you're having a cath, which is what it's called, we're not going to say cardiac or anything like that. You're just coming for a cath. So this is where all the magic happens. I have been in the lab since 2015. Before that, I worked over in Interventional Radiology, which is different side of the body. So here, all we do is the heart. Over there, you do everything.
So which one is better, interventional radiology or just?
Well, I can say that in this department, we actually do save your life. So that's probably what I like more about it than over on the interventional side. You actually do make it. I mean, we make a difference in everyone's life. I shouldn't say it like that. We do make a difference in everyone's life, but this one, you get the adrenaline rush and you're like, it's go time, you know? And that's probably my addiction to it. So that would be why I like it better over here than I did in interventional. However, you give up a whole lot of your personal time because over here you're taking call a lot. It's adrenaline or personal time, which one you want? We actually have a patient on the table right now. So right now what you hear is they're setting up the patient, setting up the equipment that we use on the patient. So here it's super important that you don't have any air in your lines, that kind of thing. So they're clearing all of the lines for everything that's going to be used on the patient to make sure we're safe. I found one of our cases that we post. So every time we do an intervention or what we call a STEMI, which is when someone's having a heart attack, we post the before and after pictures and kind of the team that was on there. This is what their vessel looked like when they came in, and so it's missing. Obviously, you can see that that's the heart attack right there. And once you get over here, you'll see that's where we put the stent in, and then it opened up the vessel. And here's where we do all of our monitoring for each case and just make sure the patient's stable. This is our NASA control room. That's what we're doing.
I'm Phil.
And this is my buddy Phil.
Hey, how's it going?
He and I actually have the same job, so yes. We both scrubbed in next to the doctor, so we're the person handing all the equipment and just making sure everything's kosher at the table. My path was I started in X-ray. I actually started at a different hospital and transferred over here. Then I went to Interventional Radiology, and then I came over here to cath. So I've been doing this for a couple of years. One of our techs who's actually scrubbed in right now, she's an artist who's missed her calling. Every week when we come in, she gives us a new lesson in cardiology. So she'll find a picture to draw and then give you a little textbook history of it. She's very good. This is Amber. She's actually our artist.
I try to do it every week or so. I put some different education on just so we can look as a team and learn something new, or even if you know it, it's just good to have up here. Yeah, so I just rotate through, do something different every week. Always pertaining to the heart, of course.
Yeah, so just trying to step up our game and make sure we are all using our brains every day. That's what every patient will look like. That's our sterile field. Everything that's blue is sterile. If you're new in the room, you want to make sure you don't touch any of that. Because we don't want to contaminate anything. But last night we got called in at 1:30 to do a temporary pacemaker. So that patient had many blockages, but we did have to pace his heart. So Russell's our coordinator. He runs the flow of the rooms and kind of get everybody flowing in a timely manner so we can get everyone done.
Chaos coordinator.
The Russell juggles cats, you know. Yeah. He puts out fires all day, so I'm just doing the cat juggling.
Well, that's pretty much what we say. We put out the small fires so we can not get them to be big fires.
Were y'all here last night? Oh.
Yes.
All three of us were.
We were.
1:30.
I'm newer, so I think of it as I came from the ER CT, so for me it's like I get that rush of the emergency room, so I don't mind it. So I'm still new to the call thing, but still, it's not, I don't mind it.
Yeah.
Call is the devil. I don't want to be a part of it.
He always says that. That's his tagline. Call is the devil.
Call is the devil. You called in at 1 in the morning, you back at 5 o'clock, and the AT's on the board. Yeah, not a lot of fun. You're new to it, of course. Oh wow, we saved their life. Yeah.
That's why that's you.
Yeah.
It is kind of rewarding when you can't help someone. You know, but you come in for the false ones that, you know, at 2 in the morning, the gas pain, really come in for this. But when someone is needing your help, you're able to come in and help them out. That's very rewarding. But then the next morning is when you say, oh, shoot, kind of painful.
Phil just needs his beauty sleep. Everyone has their role, like what they know, what they do. So Amber, Phil, and I, we all do the same job. We all scrub in next to the doctor. We are basically 100% patient contact, where the nurses are circulating the room, so they're paying, I guess, more attention to the monitors and what's going on with the patient and giving the patient medication. All of the patient's information, vital signs, stats, all of that are up here. So he's constantly monitoring that, because when we're in there messing around in your heart, we can give it a little tickle and everything can dip fast and in a hurry.
Goes pretty fast.
It gets real fast.
It's real fast.
As far as coming in after like a night being on call, I guess after so many years you just get used to it. It isn't fabulous, especially if you get called in at like 2:30 in the morning and you're here until 4, and you're like, okay, by the time I drive home and by the time I drive back, like,
Time to wake up.
yeah, it's time to get up anyway, so it's not worth it. So sometimes we just go crash in our cars and just grab like a cat nap or whatever. And sometimes we've had back-to-back STEMIs where you finish one and you're walking out the door and there's another coming in. Every day is a different day. So Dr. Willis, who you met a few moments ago, he calls this our microenvironment. So it can be very high stress. We actually spend more time here with one another than we do with our families at home, like 100% true story. And there's really, you know, at home you can go outside, you can go take the dog for a walk, you can whatever, but here you're, you know, we're stuck here with your family, for better or for worse. Yes. When you're tired and you've been up all night and whatever, like tensions can kind of raise. But also the patient comes first, so you want to make sure that you're on top of their care and make sure that you're monitoring them. Here what you see is the wire coming around the shoulder. So the catheter is going to come in over the guide wire. So where it's getting fat now, that's the catheter coming in. And it has a little hook on it so that it can engage the artery and sit in the opening of the artery, so that we can see what we want to see. And they're both arteries that are on the exterior of the heart, and that's what feeds your heart. So what a heart attack actually is, it does have something to do with the pumping function of the heart, but it's the arteries that, if this was your heart, it's sitting on the outside, and they kind of sit like that, and they feed the heart muscle itself. So when the heart isn't getting fed, and one of those arteries goes down and there's a blockage, then that's what a heart attack is. So it's not, you're thinking, most people think like the squeezing function, or their heart isn't filling, and that isn't the case. It's that the heart muscle isn't being fed with its own supply of oxygen and blood. So here in a second, once he gets engaged, we'll inject contrast, so that's what makes it look dark, and then we'll be able to see what's open and what isn't, and that's how we decide whether the patient needs to have stents put in, or they need to go, if they have multiple vessels that are blocked, then that means they go to open heart. Okay, so right now he's going to inject contrast again. The arteries are going to fill. So that's what's happening right now. So everything that's black, all of these are the actual arteries. So we're looking for any blockages. The camera rotates 360 around the patient to take it at different angles. So he actually does have a little bit of a, right here, narrowing right there. Sometimes when it isn't obvious how much narrowing is, we have a procedure that we can do. It's called a DFR, which we would put a wire down across the lesion, is what we call that. And it'll measure the blood flow before the lesion and then after the lesion. What's the D in DFR? I'm like, so FFR, which is what we always call it, is a fractional flow reserve, but I just went, I'm having a blind moment. I can't remember what the D stands for. So with an FFR, you would use medication to cause the heart to react. And with the DFR, it's all done by pressure, by the pressure wave on the wire. So there's no additional medication necessary to give the patient.
It's a diastolic
Diastolic hyperemia free ratio.
When you go into accessory,
Okay. So now this is what we call the left side of the heart. This is your LAD, lateral, anterior. Left. Oh my God. Okay, Molly, stop. Oh, that 2 o'clock is catching up with me. Left, anterior, intro.
Anterior descending.
So So this one's kind of shabby looking in here too. So he's got some blockages in there. This artery really is too small. So the size of your catheter is a 2.0, which is 2.0 millimeters. And this artery is smaller than that. So we really don't like to fix anything that's smaller than a 2.0 vessel because you can dissect it, which means kind of like a pair of pantyhose. When you put them on, you get a run, and it can literally just run down the vessel and kind of fillet it open. Bad day. So we don't want that to happen. So generally, you just don't fix anything that size. So are we calling Dr. Willis?
Yes.
Okay. So at this point, we will switch over, and the interventional cardiologist will come in and use one of our toys, which our toys are fun, to put in and see what the flow is, or if we're going to fix, which means go in and put a stent in. We have something called an internal ultrasound, and it goes in and takes a like an ultrasound picture from the inside of the artery out, so that we can see the calcium or any blockages and see what we need to do to fix it. So sometimes you still have to go to surgery, and sometimes we can do a stent. It just depends on the amount. We do all the prep. We do completely 100% patient setup and patient teardown before the doctor's ever called into the room. So usually I like to say that we do all the work and they get all the money. So, but I guess they're getting paid for what they know, not for what they do. So I'm not getting paid for what I know or what I do. So Cath Lab, so it says cardiovascular, but for us it's cardiac cath. And interestingly enough, some people freak out about that, especially men, because they only think catheter has to do with their groin, and it doesn't. There's anything with a lumen that's going in the body is a catheter. So it doesn't matter where it goes, it's just its job. And they also think, which is just a little funny side note, they also think, okay, if we say we're going groin, which remember we're actually seeing your femoral artery, nothing to do with your femoral artery on everyone is right here in the bend of your leg, right where the crease is. Everyone's is in the same place, doesn't change. And some people will freak out and go, oh my God, I don't want anything going down there, whatever. I'm like, honey. And then of course it's the keep me covered, whatever. And of course that's always, to me, I guess you become desensitized or whatever, and you always want the patient to be comfortable and not feel like they're being exposed naturally. But that's so far from our mind to thinking like, this is about your procedure, this is about your prep and your setup or whatever, and nobody's looking at anything that has to do with anything else, So yes, we're gonna keep you covered, but I'm like, it's just funny to me sometimes when that's brought up, and I'm just like, what? Nobody's got anything to do with that, sir. You're fine. You're fine. And we're also not touching that, okay? It has nothing to do with that whatsoever. Just find your artery, we're good. Find your artery right here, and you're good. And it can be, we can go to the left side of your body also. So if we had to put an impella in, which is a different device if you're having a bad heart attack and you're in cardiogenic shock, that goes in and unloads the pressure on the heart, and so it's kind of like we pump your heart for you, so it takes the strain off the heart. So that can also go on the left side. So sometimes you'll have holes in both hips and both groins, left and right. So
why didn't you become a doctor?
Well, because I'm poor, ma'am. I was prior service, I was military, and so I did my school on the GI Bill, and here I am. And at that point in my life, I was too old to go back and put that much time into becoming a doctor. Get less stress. Yes, it's less money, but it's also less stress. And to be honest with you, I like the hands-on patient care, and it's also more. I guess we're more interactive in our role, more personal with the patient. Like I like to go in there and get the patient's history and talk to them like, hey, where are you from? Especially when they're super nervous, and because believe it or not, when you're having a heart attack, you're wide awake. So we're gonna roll you in awake. You're gonna be talking to me just like now, hopefully. So I try to just alleviate your stress and hey, where are you from? How many dogs, cats, whatever, kids you got, whatever. So just focus on me and what we're doing, and that kind of makes them relax a little bit so that they're not freaking out, and we're not allowed to say, am I going to have a celestial check out in here? We don't talk like that. So I try to get their mind off of that anytime that they're super stressed and thinking what's going to happen. I'm like, yeah, we don't do that here. And that's going to be in any lab. Nobody's allowed to talk like that.
Amen. Thanks for letting us follow you around.
Yeah, it was good to have you come kind of see the voodoo that we do. So thanks for stopping by. If you got any questions or whatever, you know where to find me. But it is time to get back to the business of the day and go save somebody's life. So have a good one.